Hi everyone, welcome to our module on gallstones. The medical name for gallstone disease is cholelithiasis, and in order to understand gallstone disease, you need to recall three important components of bile in the gallbladder. Recall that bile contains bilirubin, which is a breakdown product of heme. It also contains bile salts, which are important for the absorption of fats in the intestine. And finally, it also contains cholesterol. Bile is the major way by which cholesterol is eliminated from the body. And in order for bile to remain a liquid and not precipitate into stone structures, there's a delicate balance between these three components. So the easiest way to understand gallstone disease is to appreciate that if the balance between these components is upset for any reason, that can lead to the precipitation of solid substances, and those can accumulate and form stones. Here's a picture of the biliary tree. Just by way of review, bile is formed in the liver and secreted into the bile ducts where it's concentrated in the gallbladder. When you eat a meal, your gallbladder contracts and pushes bile into the duodenum. If you have a gallstone, it can obstruct the flow of bile, and that can lead to a couple of different problems. If the gallstone is at the neck of the gallbladder, then the gallbladder can become swollen and inflamed. That's called cholecystitis. If the stone is in the common bile duct, it can obstruct the flow of bile, and this can lead to jaundice and symptoms of biliary obstruction. If the stone is here, it can obstruct the flow of pancreatic juice, and that can lead to acute pancreatitis. And then finally, if the stone is very large and gets all the way into the intestines, it can cause intestinal obstruction. That's called gallstone ileus. So we'll talk about all these problems in this module today.
The most common type of gallstones are gallstones made up of cholesterol. These gallstones are usually not visible on X-ray. They're called radiolucent. This is really not a big deal in the modern era because we don't use X-rays to diagnose gallstone disease anymore. In the modern era, we usually use ultrasound, and we'll see some pictures of that in the next few slides. There are several important associations with cholesterol gallstones that you need to know, and the first one is age. Classically, cholesterol gallstones occur in people in their 40s. Rarely do they ever occur in children or in the elderly, and a pearl you should be aware of is that an elderly patient who presents with gallstone symptoms could have a rare gallbladder cancer, and part of the reason you should suspect this is because gallstone disease is so uncommon in this demographic. Other than age and geographic location, there are a number of other risk factors for cholesterol gallstones that you need to know, and it's easier to remember all these risk factors if you appreciate the underlying principle. And the principle is that cholesterol gallstones are more likely to occur if you either have increased levels of cholesterol for any reason or decreased levels of bile acids and bile salts for any reason. Bile acids and bile salts keep cholesterol emulsified in the bile, which is mostly water. So if you either have too few bile salts or too much cholesterol, then cholesterol can precipitate and form gallstones. So the risk factors for cholesterol gallstones that we'll talk about in the next few slides apply this principle that I've shown on the screen here. So some of these risk factors are related to excess estrogen, and that's because estrogen can promote cholesterol synthesis. Other risk factors are related to altered lipid metabolism that can lead to excess cholesterol in bile. And then finally, we'll talk about a number of risk factors related to the loss of bile salts. Let's talk about the estrogen risk factors first. Women are at greater risk for cholesterol gallstones than men, and that's because women are exposed to higher levels of estrogen, and estrogen promotes cholesterol synthesis. In addition, pregnancy or a history of multiple pregnancies puts you at higher risk for cholesterol gallstones, and that's because pregnancy is associated with increased levels of estrogen, which, as we said, promotes cholesterol synthesis. And in addition, pregnancy is associated with higher levels of progesterone, and progesterone can slow gallbladder emptying. Other risk factors that lead to excess cholesterol in bile include obesity and rapid weight loss. Patients who are obese have increased total body cholesterol stores, and therefore they tend to have more cholesterol in their bile, and that puts them at risk of gallstones. Rapid weight loss mobilizes lots of cholesterol in the body, and that as well can lead to cholesterol gallstones. Both of these risk factors lead to more cholesterol present in the bile. Now let's talk about the risk factors related to loss of bile salts. And first, let's review a few principles. So bile salts are produced in the liver and secreted into the bile, but they do not all go out in the stool. Many of the bile salts the liver produces are reabsorbed in the terminal ileum. About 95% is reabsorbed. This means that there are two ways to lose bile salts. The first way is if the liver underproduces bile salts. That can lead to cholesterol gallstones. The second way is if you have poor absorption for any reason from the terminal ileum. That also can lower the bile salt pool in the body and place patients at risk for cholesterol gallstones. On the screen here is the structure of taurocholic acid. I talk about this in more detail in the bile modules, but I just want to remind you that it's got this very polar end which helps to dissolve cholesterol in water. So you can imagine that if you lose taurocholic acid and other bile salts, it makes it harder for the cholesterol to stay dissolved in bile, and that promotes stone formation. So if you have cirrhosis, you are at risk for cholesterol gallstones because your liver has been replaced by fibrous tissue and you have decreased synthesis of bile salts. Patients with Crohn's disease are at increased risk for gallstones, and that's because Crohn's disease commonly involves inflammation of the ileum. As a result, they cannot reabsorb those bile salts, and this puts them at higher risk for gallstones. Other risk factors related to the loss of bile salts include cystic fibrosis. Children with cystic fibrosis can develop pancreatic insufficiency. This can lead to fat malabsorption, and when you have fat malabsorption, you lose more bile acids in the stool. Clofibrate and other fibrate drugs are used to treat hypercholesterolemia, and they inhibit bile acid synthesis. And when you lose bile acids, this puts patients at risk for cholesterol gallstones. And then finally, bile acid resins are an old, rarely used class of cholesterol drugs. They prevent the intestinal reabsorption of bile acids and salts. That's how they lower your cholesterol level. But by this mechanism of action, they also put patients at risk for gallstones, which are a well-described complication of treatment with these drugs. Cholesterol gallstones are the most common type of gallstones, but there is another type of gallstone called pigment stones or bilirubin stones, and the reason they're called bilirubin stones is because they come from excess bilirubin. They are composed of calcium bilirubinate. These can be seen on X-ray. Unlike cholesterol gallstones, they are visible on X-ray. They're called radio-opaque. They're usually black or brown in color. If you look at this picture on the screen, there is a collection of dark gallstones in this patient's gallbladder, and those are pigment stones. The key principle to understanding the risk factors for pigment stones is to appreciate that unconjugated bilirubin is insoluble or less soluble in water than conjugated bilirubin. So any process that leads to a rise in unconjugated bilirubin level in the bile will lead to these types of gallstones. So patients who have extravascular hemolysis are at risk for these types of gallstones because they have excess bilirubin as the heme gets metabolized into bilirubin in the body. Patients with cirrhosis or chronic liver disease have impairment of liver function, and one of the liver's jobs is to conjugate bilirubin, so they will have poor conjugation of bilirubin, and this will lead to an increased risk of forming bilirubin stones. And then finally, patients who suffer from biliary tree infections are at risk for bilirubin stones. The reason is because bacteria have enzymes called glucuronidases, which can convert the conjugated bilirubin coming from the liver back into unconjugated bilirubin. And as I told you before, that unconjugated bilirubin is less soluble, and therefore it will tend to precipitate out and form these stones. Now, interestingly, the stones formed by bacterial glucuronidases tend to be brown, not black. The stones formed from hemolysis and cirrhosis are usually black, and the reason they are brown is because they have more calcium in the stones and some cholesterol. This makes them slightly different from the type of pigment stones you see in hemolysis and liver disease. Now let's talk about the symptoms of gallstone disease, and the first thing you should know is that gallstones are often asymptomatic. Many times they are discovered incidentally when we image the abdomen for any reason. In my field of cardiology, we often do echocardiograms of the heart, and when we are taking a picture of the heart, we incidentally notice that there are some gallstones in the gallbladder. When gallstones do cause symptoms, there are a number of different clinical conditions that can result, and we'll talk about all of these in the next few slides. And the mainstay of treatment for all of them is surgical removal of the gallbladder. That's called a cholecystectomy. When you take away the gallbladder, the body is still able to absorb fats, but you remove much of the bile, which is the source of the bilirubin and cholesterol that leads to gallstones, and therefore gallstones don't occur. There is one medical therapy for gallstone disease. It's not particularly effective and it's rarely used. It's called ursodeoxycholic acid. It's a bile acid. This is its structure shown on the screen, and it can be used as medical therapy for cholesterol stones only. It's not effective in pigment stones. The way it works is by reducing cholesterol secretion into the bile. As a result, there is less cholesterol to form stones. Sometimes this is referred to as an increased ratio of bile acids to cholesterol, and this is unfavorable for the formation of stones, and it can sometimes lead to dissolution of gallstones. But as I said before, it's rarely used, and the one time it is sometimes administered is in patients who have symptomatic gallstones, but for one reason or another do not wish to have surgery. So now we'll talk about a number of the different clinical syndromes that gallstones can cause, and the first one is biliary colic. This is episodic right upper quadrant pain. It classically radiates to the right shoulder blade. It's very important to remember this both for your board exams and clinically. Patients who complain of right shoulder pain, especially after eating a meal, may have biliary colic. This occurs because the gallbladder contracts against a stone that is blocking the outflow of bile. The pain usually lasts about 30 minutes or so and then subsides. It classically occurs after eating, especially fatty meals, and that's because when you eat fatty meals, cholecystokinin stimulates the gallbladder to contract. A more serious condition is acute cholecystitis. This is inflammation of the gallbladder, and this is what happens if a stone works its way into the cystic duct and causes biliary obstruction. When stones are inside the gallbladder, they can move out of the way. That's why patients have biliary colic that may last for 30 minutes or so, but then resolve. The stone will get out of the way and the bile will begin to flow. However, if the stone wiggles its way into the cystic duct, it can't move and it causes obstruction so that bile can't flow out of the gallbladder. The gallbladder then squeezes and constricts its blood supply, and this leads to ischemia. As a result, the gallbladder dilates and becomes inflamed, and that's acute cholecystitis. This is an ultrasound of the gallbladder shown on the screen. You can see a gallstone shown in white here. You can also see that the wall of the gallbladder here is thickened. That's a characteristic sign and one of the hallmarks of acute cholecystitis. The clinical features of acute cholecystitis include right upper quadrant pain plus fever and an elevated white blood cell count, and the fever and elevated white count come from the inflammation. Just like we talked about with biliary colic, the pain may radiate to the right scapula. A classic physical exam sign of acute cholecystitis is called Murphy's sign. This occurs when the examiner presses on the right upper quadrant and asks the patient to take a deep breath. As the patient is inhaling, they will abruptly stop because of pain, and that's called a positive Murphy's sign. There is a risk of rupture and peritonitis of the gallbladder, and so this condition is usually treated with urgent surgery, and you will see lots of surgeries for acute cholecystitis when you do your clinical surgical rotations. Choledocholithiasis occurs when a gallstone works its way into the common bile duct. This results in biliary obstruction and symptoms like jaundice, an elevated alk phos level that is much greater than any rise in AST and ALT, and it can lead to cholangitis, as we'll talk about in a few slides. When bile can't flow through the common bile duct, that allows bacteria to ascend and infect the biliary tree. If we go back to this picture here, when you get a gallstone in the neck of the gallbladder, that can give you biliary colic. Usually the stone can eventually move out of the way, and that's why the symptoms go away. If the stone wiggles its way into the cystic duct, that will cause acute cholecystitis. If the stone works its way down into the common bile duct, it will then obstruct the flow of bile, and therefore bile will back up into the liver, and this will give signs and symptoms like jaundice and elevated bilirubin levels and increased alk phos levels as well. Chronic cholecystitis is a rare condition that results from long-standing untreated cholecystitis. There is chronic inflammation in the gallbladder wall. This results in calcium deposition and causes a characteristic finding on X-ray called a porcelain gallbladder. If you look at this X-ray on the bottom right side of the screen here, you can see the gallbladder in the top left corner. It has white in the walls, and that white is calcium deposition. That is a porcelain gallbladder that results from chronic cholecystitis. The thing you need to know about this condition is that there is a very high risk of gallbladder carcinoma, and for that reason, the gallbladder is taken out both to treat the symptoms of the condition and also to remove the chance of gallbladder cancer. Acalculous cholecystitis refers to the development of acute cholecystitis not due to gallstones. This can happen when the gallbladder develops ischemia and there's stasis of bile flow. On imaging, you can see signs of cholecystitis like thickening of the gallbladder wall. There can also be a Murphy's sign, but there won't be gallstones. Instead, what you often see is biliary sludge. This is thickened bile in the gallbladder, and this occurs when there's gallbladder ischemia and stasis of bile flow. And usually this happens in critically ill patients, a patient who's in the ICU with shock or other critical illness, who develops evidence of cholecystitis, but imaging shows no stones in biliary sludge. That's a case of acalculous cholecystitis. Now let's move away from the gallbladder and talk about some disorders that involve the bile ducts and biliary tree. And the first one we'll talk about is relatively rare. That's called AIDS cholangiopathy. This is a rare complication of end-stage HIV infection. You have to have a very low CD4 count, usually less than 100. This isn't seen much in the era of antiretroviral therapy, but it used to occur more commonly when there weren't effective therapies for HIV. It's the result of chronic infection involving the biliary tree. Usually the infection is a result of cryptosporidium, that's the most common agent, but sometimes it's also due to cytomegalovirus, and to get both of these infections you need to have a very low CD4 count. So as the result of chronic infection with one of these agents, the biliary tree develops strictures, and this obstructs the flow of bile, and as a result these patients with AIDS can develop right upper quadrant pain, sometimes fever and jaundice, all from strictures in the biliary tree as a result of a chronic infection. The AIDS cholangiopathy is very rare, but much more common is ascending cholangitis. This occurs when a gallstone blocks the flow of bile, and the flow of bile is one of the things that keep bacteria from migrating up the biliary tree. So when the flow of bile stops or slows because of a gallstone, GI bacteria are able to ascend in the biliary tree and cause an infection, and that's called ascending cholangitis. It will present with evidence of cholestasis plus signs of infection. The classic presentation of ascending cholangitis is called Charcot's triad. The triad is fever, abdominal pain, and jaundice, and this can be seen in ascending cholangitis. If in addition to Charcot's triad you also have confusion and hypotension, you then have Reynolds pentad, and this indicates that the patient has developed sepsis and shock from the cholangitis infection. Lab values in ascending cholangitis include a high white count from inflammation, as I said before, evidence of cholestasis, which includes a high alk phos level, much greater increase in alk phos than any increase in AST and ALT, and finally an increase in conjugated bilirubin and total bilirubin. You will see this infection relatively frequently in the emergency room and on your inpatient medicine rotations. Usually the microbiology consists of gram-negatives from the GI tract like E. coli, Klebsiella, and Enterobacter. There is a very rare cause you should know about for step 1 of your boards, and that's Clonorchis sinensis. This is the Chinese liver fluke. It's a helminth that you can get from consuming infected fish. It ascends in the biliary tree, and the tip-off here is that because it is a helminth infection, the patient will present with peripheral eosinophilia. So it'll look like a typical case of cholangitis, but they will tell you that the eosinophil count is very high. They will also probably give you some clue that the patient recently ate sushi or some other type of fish. To treat this condition, you need to administer appropriate antibiotics, and you need to drain the biliary tree. Antibiotics need to have gram-negative and anaerobic coverage. Commonly used regimens are ampicillin-sulbactam or ciprofloxacin metronidazole. And then for biliary drainage, what's often done is a procedure called an endoscopic sphincterotomy. I'll show you a picture of that in a minute, where the stone can be extracted. Sometimes a stent is inserted to maintain drainage of the biliary tree, and rarely surgery is required. Surgery used to be done commonly, but now it's been replaced by endoscopic procedures where you use a camera inserted into the mouth and advanced down into the stomach and intestines rather than a surgical procedure. So ERCP stands for endoscopic retrograde cholangiopancreatography. It means using an endoscope to retrograde inject dye into the biliary tree and take a picture of the biliary tree and the pancreatic drainage. It uses a combination of an endoscope and a fluoroscope. Essentially what you do is what's shown on the screen here. Through the mouth you insert a long endoscope, that's this thing shown in gray here, and you insert it all the way down through the stomach and into the duodenum. It then has a little device that can poke into the bile ducts and you can inject dye, and then a fluoroscope can take a picture of where that dye goes. And if there's a stone, you will see that the dye avoids an area right here, for example, where the stone is present. You can then use different tools at the end of the endoscope to try and pull that stone out, and when you pull it out, the bile will begin to drain again. ERCP is done for many reasons. It's a good way to take an image of the biliary tree, and as discussed in the last slide, it can also be used as therapy because you can extract stones or try and treat strictures or other obstructions to bile flow. Here's a picture of a cholangiogram. Dye is being injected at this point right here. The fluoroscope takes a picture of the dye, which is black, and you can see the biliary tree filling with dye, and this is a way to look for strictures and gallstones and other obstructions inside the biliary tree. Gallstone ileus is a rare condition where a massive gallstone erodes through the gallbladder wall and then into the small intestine, and it creates a fistula in the small intestine so that there is a connection between the gallbladder and the small intestine. It has to be a very large stone to do this, and usually they are so large that they cause a bowel obstruction at the ileocecal valve, which is the narrowest portion of the small intestine. The patient will present with signs and symptoms of a bowel obstruction, and the classic finding on imaging, either an X-ray or CAT scan, is to see air in the biliary tree. Normally there should never be air in the gallbladder or the biliary tree. For that to happen, there has to be a hole in the wall of the gallbladder connecting to the intestines, and that's what you have in gallstone ileus. If we go back to this picture here, you have to imagine a massive gallstone essentially filling the entire gallbladder, eroding through the wall of the gallbladder and down into the duodenum, and then working its way down through the small intestine to cause a bowel obstruction. I was able to scrub on a surgery for gallstone ileus as a medical student, and I got to hold the gallstone in my hand, and it was about the size of a baseball. These are very large gallstones that cause this rare condition. You can get pancreatitis from a gallstone when the gallstone obstructs the common bile duct. If you look at this picture on the screen, if the gallstone gets all the way down here, it can block the outflow of pancreatic enzymes. Those pancreatic enzymes can begin to auto-digest the pancreas, and gallstones are a common cause of pancreatitis. The other common cause of acute pancreatitis is alcohol consumption. Rarely, patients can develop cancer of the gallbladder. This is called gallbladder carcinoma. It's a rare malignancy. It's a type of adenocarcinoma. And in order to get this, you need to have chronic inflammation of the gallbladder. We've already talked about one way this can occur. If you have untreated gallstone disease that progresses to a porcelain gallbladder, this can cause a gallbladder carcinoma. A second way you can get gallbladder cancer that you should definitely know for step 1 is from chronic salmonella infection. Salmonella typhi can remain in the gallbladder in what's called a carrier state. These patients are asymptomatic, but Salmonella typhi is hiding in their gallbladder. And in endemic parts of the globe, 1 to 4% of people may be carriers and not know it. And these carriers of Salmonella are at risk for gallbladder carcinoma. And that concludes our module on gallstones.